Hello and welcome to clinicalpath.com. Today's lecture is on asthma. Asthma is not a straightforward discussion for the medical student because it is a disease that is extremely heterogeneous. And what this means then is there's a lot of argumentation about how to classify it and how to treat it and clinically what the appropriate way to think about it is. So what we're going to do in this lecture is we're going to go to the core model disease of asthma, and we're going to base all of our thinking around that because at this level, that is the consensus opinion and the only part that's testable. So what do we mean when we say asthma? Well, the key findings of asthma are the following. The first is it is a disease of the airways, and it is a disease in which there is inflammation, and that involves the whole bronchial tree. The other element that's critical is that this is a disease of hyper-responsiveness. And that hyper-responsiveness comes in two different forms. One is there is hypersensitivity. Hypersensitivity occurs when there is increased response to a very low signal. The other is hyperreactivity. And hyperreactivity is when there is an exaggerated response to a normal signal. And then the third element of asthma is in chronic severe disease, there is airway remodeling. Airway remodeling is structural. And so when we talk about the elements of this, these are going to include the elements of mucus cell hyperplasia, mucus hypersecretion, hyperplasia and hypertrophy of the smooth muscle cells and epithelium, and collagen deposition. So we're going to go through all of the elements of that structural change when we come to the pathophysiology. Asthma is an incredibly common disease. You'll see generally quoted as 8% of our population, but in fact if you go to urban populations, it might be as high as 10 to 15%. And more importantly, it's rapidly increasing in incidence. So you're going to see more of it through your careers, not less. Part of the challenge in understanding asthma is that it's a well-recognized disease that has been understood and treated for generations. And so what this means is different people in different places have left us all of these legacy nomenclatures, which are surprisingly awkward to deal with. And let's start with the commonest problem that you get is you're going to see most people today talk about a type 2 asthma. When you're talking about severe asthmas, most people want to talk about type 2, which means there's got to be a type 1. And yet you go to look that up and it's really hard to find. And the answer is lost in the original history of this term. Back in 1977, a pulmonologist described what he called brittle asthma. And by brittle asthma, what he meant was he had patients that had severe asthma in which they had episodes of shortness of breath every day. And then they had what he called chaotic variability in their severity. And he would see his FEVs vary as much as 40% in a given day. But the very worrisome part of these patients was that they would have these really severe episodes which were really dangerous for their lifespan. So these episodes gave a high risk of morbidity to these patients. And a lot of people recognize patients in their practice like this. So over the years, the ensuing discussion broke patients into two types of severity. They were either a type 1 severity, which we meant the brittle patient that had episodes of shortness of breath every day despite treatment with steroids, had this chaotic variability throughout the day, and then had these dangerous exacerbations that were life-threatening. And they compared that to the type 2 severe asthma. And these type 2 severe asthmas had well-controlled disease. But in this well-controlled episode, they would have these periods with sudden onset of shortness of breath. And by sudden onset, that would mean sometimes minutes, but almost always less than 4 hours. And this was very problematic in the care of their severe patients because these were life-threatening attacks, and these were patients that they had carry around EpiPens so that they could survive the time it would take to get to hospital. Well, over time, people weren't really sure they could break the type 1 out from the type 2, so type 1, the brittle type, got dropped, and we were just left with the general discussion of type 2, meaning well-controlled severe asthma with these sudden, unpredictable onsets of shortness of breath. Other terms that we've used in describing asthma have been atopic versus non-atopic. An atopy is a hereditary condition seen in families that are hyperallergenic. And these are the children that have eczema and food allergies, and then an early childhood asthma that tends to resolve by the time they get to be adults. So to say someone is atopic is the same as saying they are allergenic, which means that we're dealing with allergens, so it is an extrinsic pattern of disease. And that then gets compared to non-atopic, which is the same as saying non-allergenic, which is therefore the equivalent of talking about intrinsic asthma. And when you talk to older pulmonologists or read some of the older books, you'll still see that nomenclature used. Nowadays, we're starting to see classification of asthma by cell type. And when we talk about the types of cells that we see, we're talking about the common one that we think of with eosinophils, but there is a specific type in which we mostly have neutrophils. And then there's a third type that are posse, meaning very few granulocytes. And this is widely liked because this actually correlates pretty well with the immune mechanisms of disease that are now being done molecularly. So the common one that we're now using, because it responds to the drug we use, are going to be our molecular immune. So molecular immune classifications really are what we're mostly talking about now, and that's what we're going to do our pathophys on. A new one that's coming up is going to be clinical phenotyping. And they've taken thousands and thousands of patients, and out of this they think they'll be able to tease out specific patient groups based on age of onset, based on gender, and then also based on the type of cells, whether it's eosinophils or granulocytes. There's no consensus on clinical phenotyping, so while you'll be reading about it, it really isn't testable at this point, because whether this is true and the molecular mechanisms of each is currently still being worked out. So when we talk about the pathophysiology, we're talking about our classic type 2 severe asthma. There's lots of other types, and you're going to see them written up in all the books, but in general, the one that is our default model disease is type 2 severe asthma. And there's two things that have to be explained. You have to be able to explain the gross pathology, and then you have to be able to talk about the molecular immunologic mechanisms. So if we take a look at our normal structure right here, remember it's the entire airway, but you notice the airway that we're dealing with here is a normal bronchiole. And we know this is a bronchiole because there's no cartilage. And when we take a look at the elements we want to think of that we're going to use in asthma, we have our outer muscle layer. This is smooth muscle. We have our mucosa, which is a pseudostratified ciliated columnar. And then we have our submucosa, which is where we're going to get all of the edema when we get inflammation. So when we have an acute attack, what we should be thinking of is the shrinking of the diameter due to bronchoconstriction. So this is going to be decreasing the lumen. So one of the things that decreases the lumen is bronchoconstriction. And this is where our leukotrienes really kick in as an important thing. The second thing we notice is we can see the inflammation. And with that inflammation, we're also seeing the submucosal edema, which decreases the lumen. And then the third thing we're seeing is going to be the mucus hypersecretion. And that's going to matter because that's going to correlate with our patient's cough. When this is chronic disease, then we go on and we get our remodeling. And we can see with our remodeling, we're going to get muscle hyperplasia. And that's so prominent, you can actually see that on a CT scan. When you get down to the bronchiole, which is sort of 1 to 2 millimeters in diameter, you can actually see that these bronchioles are thicker. We're going to see that there is persistent inflammation. And as we'll see, the key cell in that is going to be our T helper 2 cell. You notice this black band beneath the epithelium? That's the fibrosis. That's a hallmark of remodeling. And then you can see the mucus, there's persistent increase in mucus production. People are starting to realize as well, you see all these increase in number of vessels in the submucosa. Remodeling of the vasculature is also going to be a new part of exploration of remodeling. So remodeling then is structural defects with hyperplasia of the muscle layer, persistent inflammation, particularly of our type 2 helper cells. There's going to be increased mucus production, and there's mucus goblet cell metaplasia, and then there's fibrosis beneath the epithelium. So how does this all happen? So let's move on now and talk about the immunology of this. And I want you to think about where we are here, because when we talk about the bronchial tree, this is a disease of the whole bronchial tree. There's our first branch main stem bronchi. So that's our larynx, trachea, bronchial component. And then we have the cartilaginous ringed component. Those are going to be our bronchi. And that's where most of our airway resistance, when you do pulmonary function testing, that has the least cross-sectional diameter area. So in a normal person, that's where you're measuring your FEV1. But when we come down here to where there's smooth muscle but no cartilage, that's going to be our bronchiole. That's what's going to change in pathology to be the area where we get the most resistance. And then down the last is where we have our gas exchange. So that's our terminal respiratory unit. So this is where we're going to see, even though the whole tree is involved, this is where we're going to see our patient's shortness of breath. So initial sensitization starts with an allergen, and the allergen then is going to contact one of our antigen-presenting cells. The antigen is going to take the critical part of the antigen, and with that it's going to match up to the cognate, immature, or not sensitized helper cell. So here is our naive helper cell here, and with activation, because it hit the right protein, that's going to develop into a Th2 or antibody stimulating cell. And we talk about what the key cytokines are going to be. Always and ever with type 2, we talk about IL-2, IL-4, IL-5, IL-13, and others. We can see that's going to be critical in our discussion here, because the IL-4 is going to take our B lymphocytes and give them isotype switching so that they produce IgE. As well, it's going to produce IL-5, which is everything eosinophil, increased production, increased activation, and increased presence in the bronchial tree. IL-13 is a really complex cytokine that does lots of different things, and amongst those it sensitizes the smooth muscle so that they're hyperreactive, and as well it causes our mucus production in addition to goblet cell metaplasia. And then the last of the ILs is it becoming increasingly clear that IL-9 is going to activate the mast cells. So after exposure to the allergen, the development of our type 2 helper T cells are going to create the classic cytokine picture and the isotype switching to IgE. So after this exposure then, we've primed our patient to re-exposure. And with re-exposure now, the allergen is going to come down and it's going to bind to the preformed IgE. And our mast cell has a receptor to the Fc portion of the IgE. So the Fc portion is this fixed portion or constant portion right there. And with that then, the mast cell is going to degranulate. And with that degranulation, we're going to see the release of histamine, of leukotrienes, and of cytokines. Man, there's lots of different cytokines, but the one where it's most useful for our story is going to be tryptase. And we'll come back to that in a sec. So now when we see this release of all of these functions, this is going to be our early disease, because that's going to happen within minutes of exposure to the allergen. We can see this is going to have a number of profound effects. The biggest effect is going to be leukotriene, which are going to give 75% roughly of our bronchoconstriction. So if we come down and take a look at our smooth muscles have a cis leukotriene receptor, and so that's going to trigger bronchoconstriction. In addition, they have an H1 receptor, so histamine is going to contribute about 25% of the vasoconstriction. Our glandular cells have H1 receptors, so histamine is also going to contribute to the mucus hypersecretion. Tryptase, amongst the many cytokines, is particularly powerful in attracting the eosinophil. And so the eosinophil is going to be responsible for the second wave that we see, which is roughly starting 4 to 6 hours after exposure to the allergen. And all of the many substances of the eosinophils, including our basic major protein, are now going to give our delayed function. It's going to increase the hyperresponsiveness of the smooth muscle. It's going to increase the mucus production. And the other thing that it's going to do is it's going to actually cause epithelial damage. And so now we have surface changes. And throughout all of this, we're getting profound inflammation. So with that inflammation then, we're going to see a number of things. The first of all is we're going to see edema. And edema obviously swells the submucosa along with the mucus now giving us much smaller lumen. As well, we're going to see abundant cells. That's going to include both our neutrophils, our polymorphonuclear cells, but it's also going to include our T helper 2 lymphocytes. And now we're going to amplify the whole signal process with IL-4 for IgE, IL-5 for eosinophils, and IL-13, which increase the whole inflammatory process. So that then becomes our sensitizing and then acute response exposure pattern for our classic type of allergic bronchitis. Okay, well, with all that, what does our patient look like? So this is during two different patterns of patient presentation. We can have an acute presentation, or we can have a patient presenting with chronic disease, meaning they get, say, 2 episodes a week, but when they present to you, they're not in acute crisis. So when we talk about the symptoms of acute, we're talking about the patient often feels a tightness in their chest. And obviously then they have shortness of breath and wheezing. But remember, all of that mucus production is critical because cough might be the only symptom that you get. So difficulty breathing and cough are your classic symptoms. When you're dealing with your chronic symptoms, well, that's going to be a problem if they're currently having a relief. So we're going to have to now talk about what to do between attacks. When we talk about the signs, again, we're talking about acute here. We're talking about our wheezing. And we're talking about typically early on an increased respiratory rate if the obstruction isn't so severe that we started to see the patient go to slower, deeper breaths as a more efficient way of breathing. So when they walk in with their acute wheezing then, what are we going to do? Well, there's a difference between the ER and the office. So if we're in the ER, then we recognize, to prove that it's pulmonary, I suppose you could do pulmonary function testing, and as an obstructive disease, we'd see that our FEV1 over FVC is going to be less than 80%. But from a pathologic perspective, the acute attack of asthma is reversible. So if you're really struggling with whether your patient is having that from asthma or not, then what you're going to use is you're using a short-acting beta agonist like albuterol and show that you can improve that patient function. So reversibility is the hallmark of acute asthma. When we're talking about other tests that we could do we use arterial blood gases? You're really not going to worry about that till you get to failure. Certainly you could use a pulse oximeter to look for hypoxia, but remember the oximeter is not really good at mild levels of disease. So your key function here is going to be less than 90% saturation, because that's going to be our marker of going into failure. Chest x-ray really doesn't have a diagnostic role in diagnosing asthma. It's quite useful for ruling out other diseases, such as a triggering underlying infection. So that would be useful. Well, chronic, again, what we want to do now is, if they're between attacks, they really might have a normal FEV1, FVC if they haven't had a lot of remodeling yet. So in this case, instead of showing bronchodilation by using a short-acting, instead what we would do then is you could show that they are going to decrease it with a provocation test using something muscarinic like a methacholine. But at the end of the day, you want to prove that this is the allergic type pattern of our Th2 cells. So one of the common tests you're going to use is you're going to use blood eosinophils. Because if that's elevated, you know that that has got to be due to IL-5. Tertiary centers are doing sputum eosinophil counts. Turns out that's actually quite hard to do and requires a very disciplined protocol, but if you can do it, it's a very good test for proving this is a Th2 pattern, and so this will also be related to IL-5. And then the last test we can do is a newer test, which is our fractional excretion of nitric oxide. And this is a general marker of inflammation that correlates with our levels of IL-13. So those are the tests you're going to be doing in your chronic asthmatics to prove the underlying inflammatory process and cell type. And this is useful because it correlates with our drug use. Almost all of these drugs have some sort of decent response to inhaled corticosteroids, but they also indicate likely success with the currently usable anti-IgE and the current new anti-cytokines that are in development and going through the trials right now, which is going to be our anti-IL-4, IL-5, and IL-13. So these are all coming through now. They're not testable yet, but they certainly would be useful as a thought experiment, wouldn't they? So how are you going to treat your acute attack? Well, obviously there's a lot of mucus, so some people can use mucolytics, just to mention it while we're here. But basically you're going to differentiate them into two groups. You're going to differentiate them into those that are offering relief, which is basically bronchodilation, and then chronic control by decreasing inflammation. So what are the drugs we can use in relief? Usually the drugs you're going to start with are going to be our beta-2 agonists. And the beta-2 agonists can be short-acting, and that's basically our albuterol. Or they can be long-acting. These are mostly used in COPD, but you'll see them used in asthma as well. And our long-acting then is going to be our salmeterol. In the other types of chronics, if the beta agonists need help, then we can go to our anticholinergics. These are mostly going to be M3 antagonists. And these again are mostly used in COPD, but you'll see them used in asthma. And a common example you're always going to see is going to be your tiotropium. And then the last of the relief, it isn't so much used in acute as it is as a supplemental drug, is going to be our theophylline. Turns out theophylline is a really complex drug that probably does immune modulation as well, but if you're asked for its common mechanism of action, it's going to be a phosphodiesterase inhibitor, because that's going to give us higher levels of cyclic AMP and bronchodilation. When it comes to controlling, it's always going to be starting and ending with inhaled corticosteroids. And these have multiple complex actions directly at the gene level, but this is absolutely where all control starts, is starting with low levels of inhaled corticosteroids and going to high levels. And if this then doesn't give you relief using your albuterol and control using your inhaled corticosteroids, then you start adding other drugs. So for example, you can add theophylline, you can add the chronic bronchodilators, but some of the other drugs that have been used, you can actually stabilize the mast cell membrane so that it doesn't degranulate. That's our cromolyn. Or you can use an anti-IgE. This is our omalizumab. also preventing the leukotrienes, which are the key mediator of bronchoconstriction. And there's two ways that you can inhibit the leukotrienes. You can actually inhibit the interaction at the receptor level. This is going to be the drugs that end in lutrast. Or you can prevent the production of it by having a anti-lipooxygenase so that you can't synthesize the leukotrienes, and this is going to be our Zolotin. Currently in trial and looking as though they're going to be positive, but probably not at the state where you can be tested, are going to be the anti-interleukins. So anti-IL-4, IL-5, and IL-13 are looking very promising as therapeutic actions. And while we really can't use them yet, they certainly would be good for using as a thought experiment, wouldn't they? Okay, so that brings us to the end of our discussion about asthma. What should we think through that we should be doing as our summary here? Well, the first thing to remember is the definition of asthma. It's a disease of the airways, all airways, but the pathologic effect is going to be at the level of the bronchiole, and it's going to be airway inflammation. Remember, the key cells that we're talking about in inflammation are going to be our basophils that degranulate. They're going to be our eosinophils that cause broad spectrum changes, and they're going to be our T helper 2 lymphocytes, because they're going to be producing our IL-4, 5, and 13 that are really the fundamental basic hallmark of this disease. Remember, when we talk about the pathophysiology, we want to talk about the anatomical structural changes of remodeling, and we want to be able to talk about the immunologic pathophysiology, which is going to be one of sensitization, and then during the acute attack. When we talk about what our patient looks like, we want to be able to describe an acute attack with its wheezing and cough, but remember, this is where you're going to use your short-acting beta agonist to show reversibility. When we get into our chronic disease, if they're between attacks, this is where we're going to use our provocation test to show that you can induce the bronchospasm. And it's an obstructive disease, so when we talk about our pulmonary function testing, we're going to see the FEV1 over FVC of less than 80%, as we do in all obstructive diseases. And then lastly, it's really important that you're able to do the treatment. And remember, the pharmacology is going to break into those that are relievers. And so that's going to be basically bronchodilation. And our key drug here is going to be our short-acting beta agonists like albuterol. And then between attacks, we want to use our controllers. And so these are basically going to be anti-inflammatory. And these are going to start with inhaled corticosteroids with increasing doses, and then we're going to add drugs in as we have progressively more severe disease and loss of control. So that brings us to the end of this tape. Thanks for listening.